Welcome, ladies and gentlemen, to this, the March or February board meeting of the Wye Valley Trust. We're delighted to see you again. As you are aware, we are continuing to face the challenges of the pandemic. And before we start the board, I want to put on to public record the board's recognition and enormous thanks to all of our frontline teams and colleagues. We've just, before we've gone live on YouTube, celebrated our Going the Extra Mile awards for certain employees and teams who have been outstanding. But the reality is all of our colleagues, all of our frontline teams, those on a patient-facing workload and those behind the scenes are performing exceptionally well, going the extra mile, and doing so with real physical and emotional demands placed upon them. So on behalf of the board, I want to say thank you. I also want to put on record my thanks to all those family members who behind the scenes have made enormous sacrifices to support their spouses or their mums or dads or loved ones during this period. The board recognise the challenges you face, the demands put upon you, and on behalf of the citizens of Herefordshire as well as the board, I want to say thank you. So I don't think we could have any apologies for absence, Erica. So any new declarations of interest? Please raise your digital hand if there are. Okay, so we'll move on to the last set of minutes. Was everyone happy with the accuracy of the last set of minutes? Please raise a digital hand if you are not happy. Okie dokie, so we'll move then on to matters arising, which is on page 14 of our pack. The first was how to review how typical the substantive medical staff additional payments are and compare these with other trusts. Howard, you put a pretty comprehensive reply in there. Anything you particularly want to emphasise?
No, I was conscious that this was a sort of longer response than normal in matters arising, but I did want to highlight this has, of course, been on the matters arising for quite a few board meetings. So I wanted to be clear that work is being undertaken on a group basis and that more detailed work will actually be following. So I thought that it was appropriate to put this detailed answer in the papers at this point.
That's great. Thank you, Howard, and continue to keep us briefed on that, please. The second was, John, to review whether the increase in emergency readmissions and increased length of stay is having an impact on bed occupancy and flow. We come back to that later, John, in your report, yeah?
Chair, I sent out a quite full response at the start of January, I think it was.
Okay, apologies. I missed that, John, because I've been unwell. I apologise.
Sorry.
And then the final one is on workforce. Frank to discuss this with the steering group and Jeffrey in regard to promoting employment in the trust. And I understand that's been done, Jeffrey and Frank, so thank you. Any other matters arising that we've missed? Okay, super, thank you. So we'll move on then to the Chief Executive's report. Glenn, over to you.
Thank you, Russell. So quite a lot in there this month. I'll just go through some of the highlights from the report. First section talks about some really important legislative changes that are being proposed for the NHS. And despite all the pressures of COVID, this work went on prior to Christmas and consultation then closed in January. And I've contained within this report some of the feedback we've given to that consultation, but also an explanation of what these changes would propose. And if they go through the parliamentary process to plan, they would be implemented from April of next year. But indeed, there's a lot of things that we could progress earlier than that. Main thrust of it is an unwinding of the what's often referred to as the Lansley reforms and move away from the competition approach to more collaboration. And I reference here the fact that our group model is a fine example of how providers can collaborate in order to spread best practice at pace and and in order to improve productivity and efficiency. So one of the key things for me in this is a real focus on place, and for us, Herefordshire being the main place with Powys that we provide support to. But moving to a lead provider model will be an opportunity for us to step up more and take that responsibility for population health and integration in the places in which we function. And that's something that's been our strategy now for a number of years, and there's been really good progress being made on it. And in fact, as I look on screen, I can see the strategy behind Mrs. Ives in the background there. So this really does allow us to accelerate the work that we've already started. But there are two options around how integrated care systems work. The preferred option being that we create an integrated care system body, and that we would be members of that, but it would bring some independence into integrated care systems, and they will be moved to become more strategic. I also made the observation here that I think there's a question mark about, particularly in our region, about whether we need those to be over a slightly bigger scale in order to be strategic and to allow place to develop. But alongside the move away from competition, one of the cautious points I would raise is that in the acute sector particularly, the focus on productivity and efficiency that tariff has driven has allowed us to get much more of an understanding of cost and to improve productivity. So I wouldn't want to see us lose that as we move to a system where we're likely to be funded for capitation rather than the individual procedures and operations that we perform. So getting it right first time, using still a focus on the performance of individual organisations and using individual organisational governance rather than system governance as the main way of making things happen. But in summary, support it. It allows us to move forward with the strategy we've had for a little while now. Then there's a section that talks about our clinical support division and highlights some of the great work that they've been doing over the past few months. It starts with the incredible response to testing for COVID that our laboratory teams have been able to deliver. And indeed, only yesterday we were notified that we are going to be piloting a new, more rapid testing solution at Wye Valley, which will help that even further. We've rolled out lateral flow testing to staff. We've significantly ramped up the ability to provide rapid testing near to patients. And then on cancer services, the huge increases in activity that we've seen and the maintenance of still some really good performance targets, that's been challenging over the last couple of weeks, and I'll talk about that a little bit more when we talk about critical care. Diagnostics, alongside everything that's been going on, we've been upgrading and replacing equipment with CT scanners, and we will be replacing a third CT later on in the year, second MRI machine also. So some fantastic work there. Pharmacy also have been doing some work in implementing electronic prescribing, which is an enhancement we've been looking at for a number of years now. That started and will soon be completed. And then the virtual outpatient work from our patient access team. So loads and loads of good work. So not only responding to big increases in demand, but innovating all over the organisation. On testing, I've talked about that, so I won't say any more. Rapid testing is referred to there. And then the other thing that's been stepped up, and great credit particularly to Erica, who's helped to pull this together, but also Lucy and many others, that we've been able to start delivering the Fisa vaccine to staff, but also to care workers and to our top 4 vulnerable groups according to the national prioritisation, and this rollout will continue. It's fair to say that Hereford and Worcestershire is one of the leading STPs in the country on our rollout so far of the COVID vaccine. And unlike other parts of the group where we had the relatively easy AstraZeneca, we've been using Pfizer most of the time in Herefordshire, which adds a little bit of complexity to it. So great work from the team there. Critical care, finally, indeed, today there's a story in the Health Service Journal which looks at the amount of capacity that trusts have increased in order to respond to COVID. We were asked to step up by 175% or 200% in order to decompress Birmingham, but also so that the Midlands could decompress London. And we've done so tremendously well here. We also expanded our critical care, board members will recall. And in the Health Service Journal, we're one of 3 trusts that has gone more than 3 times its capacity, 300% capacity compared to last year. That is relatively easy to do when you talk about the physical space, but it's really hard to do in terms of staffing and the pressure that it puts on our workforce. And we've had to move staff from theatre. We've had to pause some of our surgical activity, and we're doing some of our cancer work in the independent sector. So it's a tremendous amount of pressure. We have been supporting that team and other teams with psychological support, but as you say, Russell, we will need to look at how we do that even more so over the next year as we hopefully exit COVID. And then finally, a full list of all the nominations for employees and teams of the month, including the winners that we just celebrated at the start of the meeting. So I'm happy to take any questions on that.
Thank you very much, Glenn. And just before I invite any questions or perspectives, absolutely outstanding, I think, performance from Wye Valley as part of the Hereford and Worcester ICS. We've definitely played our part across a whole variety of different aspects in terms of vaccinations and mutual support. So well done, team. Any questions or perspectives to Glenn? Please raise a digital hand if you have. Physical hand from Richard.
Hi, Glenn, very much agree with your comments on the integrated care system developments. I do think we will need to be continuing our vigilance in making sure that we have the freedom locally to find Herefordshire solutions to Herefordshire needs, and that we don't get sucked into wider regional or national kind of top-down stuff that prevents us from doing that. And the events of the last few weeks, particularly the vaccination, demonstrates that the best things that are going on at the minute are locally driven by local staff in response to local needs, and we need to hang on to that.
Thank you, Richard.
Yeah, really good point to emphasise. As I say, I think the best thing about the national legislation is it really recognises place, and actually the national team are looking at Herefordshire as a really good example, which we can hopefully work with them on implementation of some of this at an earlier point than the following April. So yep. It's certainly the best model, and we've proven that.
Yep. And any other questions to Glenn? Otherwise, we'll go into the detail of the integrated performance report. And Chris.
Sorry, I did put a digital hand up. It's obviously not appeared. I just wanted to commend everyone at this difficult time with all the innovative things that are going on that will benefit patients in the years to come, and to continue to give lots and lots of airtime to these developments. I think it's remarkable what's been done in these difficult times, and credit to everyone. But it will be, you know, so supportive for so many years to come. Thank you.
No, absolutely, Chris. And it is, you know, I think something that the people, citizens of Herefordshire, can be really proud of the way Wye Valley has, over the last few years, really come on in terms of delivery for the citizens of Herefordshire. Colleagues, happy to move on? Okie dokie. So Jane, do you want to introduce the integrated performance report, please?
Yes, I will do, and I'm really at risk of repeating quite a lot of what you've said and Glenn said, but it might be worth repeating. I mean, I noted in my opening of the report that it's 2 months since we had our last or wrote the last report, and it's just, yeah, the turnaround and what happened. I don't think we could have predicted that. I think we knew it was going to go up a bit once we came out of the November lockdown, but actually what happened was so much more than we were anticipating. And so we are, as we sit here today, we are certainly over that this third wave that we've been in. Our community rates are down from, they did get to about over 400 per 100,000, and we're down to about 140 now. And the number of admissions per day has also dropped. and the number of inpatients, although we're still carrying a significant number of inpatients with COVID in the trust. So the size of this surge was, in terms of number of patients that we had in the trust, is much more than 3 times the first wave. And we were managing that along with winter pressures, and we were managing that along with trying to do what we could in terms of the recovery programme. And as Glenn's mentioned, supporting the region in terms of extending our ITU capacity and taking some patients from the rest of the region. And at the same time of that, and I think I mentioned this in November because we were planning it then, but particularly to Lucy and Erica and Tony McConkey, what's been put in place in terms of our local vaccination programme for our own staff and for social care staff has been a really effective, efficient operation, and it's now moved up to Elgar House. We've done almost all of the staff, and I think it's about 80-20, so 80% of our capacity now will be joining the effort to vaccinate the public. There's no doubt that in Herefordshire we will meet that target of the first 4 JCVI categories being completed by the middle of February. So it's been a huge and really impressive effort. But I guess at the same time, we know that we've had to stop a lot of non-emergency work, and we know there'll be unintended consequences for some of our patients of that. I think we've done and could have done no more in terms of clinical oversight and mitigating the risk of that, but with very long waiting times and people on waiting lists who've been there for well over a year, there are consequences for those people, some of which we won't be able to foresee. And I think it just demonstrates how difficult it's been for the health service to continue to do its normal work during this last surge again. And then really, as both Glenn and Russell noted, there's an impact for all of our staff on this as well. So from the working longer hours, working in PPE, which is uncomfortable, working in unfamiliar settings. But I know Lucy did a walk around last week, and the biggest issue for staff was sort of the emotional burden of managing breaking bad news to lots more families than they normally would, and doing that in a remote way, which is incredibly difficult. And so that there is a consequence for our staff as well, and the sort of emotional and physical burden that they've been they continue to carry. So we have stepped up our health and wellbeing offer. Jeffrey will say a bit more of that later on, and in private board. But we can't do enough. We can't do too much in terms of supporting all of our teams and the extra effort that they're having to put in, and the consequence for them and their family. Just before Christmas, we had a CQC inspection of our urgent and emergency services, which had been triggered because our sort of headline performance on the 4-hour target has been pretty poor. So they wanted to come in and make sure that our services were still safe, even though we got some longer waiting times. We've received the draft report of that this week, and obviously we'll release that when it becomes public and it's no longer draft. But I think it's important to note that we have retained the good rating for our urgent emergency services, and there's a huge amount of really good practice that they noted as part of that visit. And what we are doing, we've got later on the agenda, is the business case for extending the environment for urgent care, so that the innovations that they've put in over this, we can make sure the environment really matches the work that they're doing. So really, that's really what I wanted to say. My opening comment today was just that thank you to the commitment of all of our staff in providing care to the population that we serve.
Thank you very much, Jane. Any questions to Jane, or would colleagues prefer to get into the detail? Nicola first. Nicola
Hi, Jane. I just want to say thank you, Jane. I think on a purely human level, I think what Hereford's achieved is amazing. and talking as a Herefordian with lots of elderly family members, what that has meant and the peace of mind they've had for getting through quickly, it's been brilliant. And I took Mum on a very cold day to Saxon Hall, and the queues outside were quite long, because and it was 9:30 and quite chilly, but no one was moaning, and there were octogenarians everywhere taking selfies, which I just really made my morning. So I thought that was great.
Okay, great. And Frank?
Yeah, the mutual aid question, it's been very, very helpful to see the bulletins and just try to get a feel of direction to travel and the pressure you're all under. But of course, we don't know what dimension of that is mutual aid. Is there anything you can do to just give us an indication of how big that helps be?
Well, we've had some support from the military over the last, they started last week, so they're here for the next couple of weeks. So they're supporting with a number of things. In terms of vaccination, we've been helping each other out with the hubs and our own vaccination programme. And I think the biggest thing we've done in terms of mutual aid is around intensive care, and so taking some of those patients from Birmingham who required.
And how many is that, Jane? Roughly?
It was at 3 or 4, I think. So not huge numbers, but the patients do have a long length of stay in ITU. So in terms of our overall capacity, which we increased to 16, it was actually quite a significant amount of our capacity.
Okay, thank you, Frank. Thank you, Jane. Okay, colleagues, happy to go into quality with Lucy. Over to you, Lucy.
Thank you. Good afternoon. I'm going to take the report, if I may, largely as read, partly because probably Glenn and Jane have covered some of the points I would have wanted to make. So I'll touch on a few, and then I just want to share a little bit more about my walk around with the staff last week, if I may. So Quality Committee met last week and received the full Falls quarterly update, and I put a little excerpt from that report into this report. So just to say that our Falls rates fall within expected parameters. Only 2% of patients fall in our care, which benchmarks well. Those who do fall, we have a relatively low harm rate, which is good. What we have seen, along with many other trusts during the pandemic, is actually, though, an increasing number of falls during the pandemic. And I think we touched on that at a previous board meeting. That's partly due to individuals coming into hospital that perhaps deconditioned due to being locked down and potentially not as active as they would have been previously. We know that the people coming into hospital are much sicker and frailer. And we're delivering care in a very different way, where some individuals are having to be cared for in rooms with doors closed. There's a national piece of work that's just been commissioned around falls during COVID, and we're participating in that work and have agreed to feed that back to Quality Committee in due course. You can see in the report that mixed sex breaches remain high. We do try to avoid placing men and women into sleeping areas together. We know that it's not what we'd want to do, it's not what we would want for our loved ones, but given the challenge of having to keep COVID positive and amber patients separate, we are restricted, and there are times when operationally the only thing we can do is place men and women together. Complaints have, the numbers of complaints coming through have increased in the last 2 or 3 months. And it's a really tough one, actually, in that the most common theme in the complaints is around communication. And I think partly that's driven by the, you know, we've had to restrict visiting, and we've had to restrict visiting further because of the new variant of the virus. Staff are busy and perhaps not able to proactively pick up the phone to tell relatives about their loved one, just one for us to watch. I have spoken to our volunteers coordinator to see if we can get volunteers more volunteers onto our wards to try and support that proactive communication with their relatives and their families. And then the last bit I really wanted to touch on was staffing, because since the week before Christmas, staffing has been particularly challenging, partly driven by the fact that a number of our staff themselves have contracted COVID or have had to self-isolate because they've been in contact with a family member who has COVID. Our demand for agency staff is very high and the agencies aren't able to meet that demand. So we've seen a dropping off of agency provision, increasing demand for agency, and therefore increasing Thornbury usage, so those expensive agencies that we would prefer to avoid. As Jane and Glenn alluded to, we've had to redeploy a huge number of our staff, 45 whole-time equivalents, to support critical care, so the intensive care unit, and then backfill the gaps that they leave by standing down services and moving nurses from the practice education team, from outpatients and other areas to backfill the gaps that they leave on the wards. And that sort of leads me on to my walkabout, really. I was lucky in some respects that for the first time in a year, I had a 3-hour space in my diary with no meetings in it. And it was the highlight of my week last week, because I was able to go out for 3 hours and talk to the staff in every single one of our wards, including critical care, theatres, and each of our wards on the county site. I've yet to get to the community sites. And what I saw was great teamwork, great camaraderie, and great team spirit. Even those nurses who described to me feeling like fish out of water, who perhaps moved from outpatients into a ward setting or moved from their specialist role into a ward setting. But they're tired. They're coming to work in the dark. They're going home in the dark. And they are struggling, as Jane alluded to, with making sure that those patients who experience the end of their life in our care are being cared for the best that they can be. And the nurses feeling that they're not doing the best communication that they can with those family members, and going home and with a heavy heart that they haven't perhaps been able to communicate or enable visiting for those family members in the same way that we would do normally. And that was certainly hanging heavy on many of the hearts of many of the nurses that I spoke to in many of the wards that I visited. And what staff described, and it comes as no surprise really, all of those things that normally help you cope under pressure, the pandemic has taken away. We can no longer hug a colleague, we can no longer share cake and have a coffee in the staff room. And for those who like to go to the pub, they can't go to the pub either with their mates. And so all of those coping mechanisms that help a bad day feel better, they're not able to do. And that's why I think it's really great that the work that Jeffrey and his team are doing in terms of expanding that health and wellbeing offer is really, really important. Thank you.
What a great summary. Thank you, Lucy. And questions or perspectives to Lucy? Grace?
Thank you. Just building on what you said around falls, and we heard more about this in inequality. I'm understanding that patients are coming into hospital sicker and deconditioned, and just wondering, are we looking at the best practice on working with these patients in this different state might be? We needed to update our practice and guidance to account for this, or is this already being done?
So we're still adopting best practice where we can. So we still have the ethos of NPJ paralysis. So get up, get dressed, get moving where that's possible. I mean, clearly there are some individuals inside rooms where they can't come out and walk about. We're still offering physiotherapy and therapy input to patients. I think it's just the nature of the pandemic. And I think this national piece of work that's been commissioned will help us understand that more and see where we may need to change what we're doing.
Okay, thank you. And Glenn, do you want to add to that?
Yeah, it was just picking up on the point that you flagged in the report, Lucy, about same-sex accommodation breaches. And the numbers are obviously higher than we've ever seen, and for understandable reasons. But there's two definitions to this, aren't there? One is where patients are in the same bay as a different sex patient, but also when people are sharing the same access to toilet and bathroom facilities. What's our situation? Is it more of one than the other?
We count we can do some detailed analysis to see which are bathrooms and which are sleeping facilities, but I'd have to go away and look at that. But I would say that we're a high proportion are at the end we wouldn't want them to be, which is individuals sharing the same sleeping quarters. So on our Nightingale wards, which we're not able to keep a male ward and a female ward, and within our bay areas because of the cohorting.
Okay, so
we can maybe just do a paragraph next month, Lucy, on that. That would be great. And Andrew?
Yeah, it's just to pick up on the agency issue, and it's we considered a report on agency in the audit committee, and it basically concluded that we can, as a board, take assurance that it's not our systems that's the issue, it is the activity and the demand for additional staffing that's the problem.
No, that's helpful, Andrew.
It's a good place to be, really, from a systems point of view, anyway.
Yeah, yeah. And I don't think we're in any way unique in terms of the challenge of the use of agency at the moment. Okay, team, colleagues, happy to move on to John's update on activity. So just keeping things going because we've got some chunky items on the agenda. John.
Sorry, thank you. Just a few points to pick out, really. Just wanted to talk a little bit about demand. So demand referrals for electives are still behaving quite unusually. 2-week wait referrals have returned to normal levels, which was higher than we'd expected. Urgent are still remain below where we would expect, and routine and have hardly moved for a few months now. So still quite an unusual picture with referral for elective care. Emergency care, we had seen a return to normal levels through the autumn, but since the the most recent surge, and activity levels have again fallen, not to the levels we saw in surge 1, but they are down. The impact on capacity as a whole really has been driven probably not by front door demand, but by COVID prevalence, really. COVID prevalence in terms of patients being admitted. Jane talked about the numbers. I think at one point we were up to about 6 patients on average per day being admitted with COVID, which for a bed base of 242 is a significant cumulative proportion, but also that driven by outbreaks. In fact, at one point, outbreaks were driving occupancy for COVID more than admissions, but admissions rapidly took over. So that coupled with the need, you've already heard about ITU demand and the need to release staff and staff absence, have created a significant amount of capacity pressures, which have led to some of the things you've already heard about, really. We've had to cease all routine outpatients, all planned surgery, including cancer and urgent surgery on this site. But we have retained, and it's important that we have retained all diagnostic care and or endoscopy care throughout this period to try and maintain, we don't build up a backlog. So we have negotiated a locally agreed solution with the local Nuffield private hospital, and we are carrying the majority of our cancer work out in that facility with our surgeons operating on patients. And whilst we have ceased for the last couple of weeks all surgery on this site, we are hoping to reinstate that, subject to a few tests. In fact, we're talking about that again straight after this meeting at 4 o'clock this evening in our COVID meeting, to see whether or not we can approve the restart of a limited volume of cancer work on this site, which is really important that we do that. In terms of imaging, just really pick out, MRI remains a concern. It's driven by staffing rather than state resources. There is a really good plan in place, and we do have an staffed MRI coming on site in the next month or two that will actually help us get back to normal waiting times for MRI. The rest of diagnostics are doing really quite well. And for this positive, really, I'm not going to talk about it in a while, but the same day emergency care facility that currently exists has done a really good job through COVID, and at one point we got back up to 38% of patients being seen and discharged on the same day, which is fantastic. And the physical facility that's being currently built will be open in the coming weeks that will allow us to do that even better. But one thing we haven't talked a lot about really here, and perhaps we'll talk about it later a little bit, but the system has always worked really well together in my time here at Wye Valley. But the COVID pandemic has allowed the way we deliver urgent care to develop really rapidly. And SDEC is one part of what I believe is bringing primary, community and secondary care's urgent response together. So I just really just wanted to say that the work's progressing really well. The team are working really well together, and we're seeing some really good instances of primary, secondary, community urgent care developing through 2-hour response and etc. That's all I wanted to raise. Thank you, Chair.
Thank you, John. And on that last point, well done to your leadership in sort of driving all of that stuff forward during these difficult times. Questions and perspectives to John? Frank?
Can I just highlight the statement in the papers, the first in the country to deliver 111 first? You know, it's nice to be first in the country for anything, and that's brilliant, John. Thanks.
Yeah. And finally, Glenn?
Just worth also adding that as board members are aware, we received a letter of praise from West Midlands Ambulance Service for the help in turning around their ambulances to keep them on the road and keep patients safe. So it's really nice to see that from our colleagues at West Midlands Ambulance.
I think the phrase used, Glenn, was exemplary behaviour, which is really great. Okay, colleagues, we'll move on then to Jeffrey. Jeffrey, update us on how you're seeing things, please.
Well, thanks, Russell. I mean, the report highlights where we are with key HR and all the interventions, but I think the key thing has been the support that we have in place and the whole drive on the health and well-being agenda. As Lucy mentioned, though, that takes a key part of what we've been doing over the last few months. So we've got an active working group in place made up of, not just clinicians, but staff across the trust, including our trade union reps and occupational health. And we meet on a monthly basis just to try and understand whether there are any other types of interventions we can put in place for staff. We've launched our weekly health and wellbeing publication where we're bringing together all the interventions we have just to remind people of the support out there, and that will be ongoing for the next few weeks. I did a video last week, I think, on health and wellbeing. Hopefully you've all seen the video, and I hope you like the video. So we're really doing a lot of stuff on health and wellbeing going forward. So the report also highlights on the final page just where we are with a number of HR OD types programs for Wye Valley. And you can see it's quite a busy agenda. And the final thing I wanted to mention was we are doing a massive recruitment campaign with Indeed on healthcare support workers. So we've gone live today. So over the next few weeks, we're going to be recruiting local people to come and work for Wye Valley. So just watch out for the recruitment campaign, which went live today.
That's great, Jeffrey. And I'm looking forward to the day when you're a TikTok star and we'll all be able to celebrate you having 1 million subscribers. Just before I invite questions or perspectives, just a thought. Hereford has a very proud association with the military. I'd just like to ensure, particularly Jeffrey with Erica, that we are making sure that where possible, if our military friends have got experience of helping colleagues with PTSD and any modules or support modules, that we learn from our military friends in Hereford, because a number of the colleagues at Wye Valley obviously have loved ones who work in the military. So it seems something that would be an obvious and sensible thing for us to make sure we fully explore. And I know, Erica, you've got some associations there. So if I can leave that between you and Jeffrey, that would be great. Because I am very concerned that our staff are experiencing things that, unless, frankly, they've worked in a war zone in the past, and some of them will have done, they will not be experiencing the level of emotional intensity and despair that they've had to live through over the last year. Other questions or perspectives to Jeffrey? Andrew?
Yeah, really useful to have the non-substantive budget establishment in the paper. I presume that's to do with the response to the COVID. It's just a small point really on appraisals, which obviously I guess you see as part of the wellbeing initiative. You make the statement that due to some staff working from home and COVID, that managers conduct, there's a bit of delay. I just wonder what's the delay around working from home, and presumably staff can get the face-to-face through Teams and stuff
Yeah, I certainly think they still have the obviously the interactions and the support from the line managers. I guess it's more along the lines of the operational pressures within the trust, which means that the formal appraisal process, because of the time commitment required, hasn't been acted upon, not just for those working at home, but in general. So I think that's just what I was referring to.
Okay, thanks, Jeff. Thanks, Andrew. Just conscious of the time because we're running about 5 or 10 minutes late. Frank first.
Yeah, very quickly, if I can encourage the whole family approach. We've just seen an example of it with Nicola, actually, how pleased she was to see her mother get vaccinated. And there's a lot of evidence I'm seeing in the community, especially through the Community Foundation, that a lot of stress and strain is on employees, not because of their job, but because of the family-related issues. I'm not suggesting it's easy for a big organisation like ours, but I think there's something there that if we can just identify or help them identify how to get help with their family issues, it could be useful.
No, point well made. Thank you, Frank. And finally, Chris.
Thank you, Chair. I just wanted to welcome the increased information on exit interviews, but particularly wanted to link in with the new recruitment that you've just talked about, that the reason most, I think it's HSAs are leaving in the additional clinical services is because of lack of career progression. And just wanted to be assured that that's part of the whole recruitment process, that there's no point in recruiting unless we've got a plan to keep these people. Thank you.
Yeah.
Absolutely. An obvious point, Chris, but often forgotten, I think. So colleagues, happy to move on. Great to see Joy and Amber joining us, so we'll be with you as soon as we can. Howard, tell us about the money.
Okay, thanks. Just 4 key points I wanted to bring out today. Firstly, I mean, obviously the financial position is quite a turnaround since our last meeting when I was reporting on the position at the end of October. The plan, of course, we produced a plan for the second half of the year and is based on certain expected levels of activity, which, as we've already heard, haven't come off. And so at the end of December 2020, we were actually in a position where we were £4 million better than our plan, and we were actually showing a surplus of £2 million. So quite a change in position. The second point Lucy has already referred to, but essentially nurse agencies has been creeping back up, similar level to the end of 1920, and increasing use of Thornbury, but primarily, as Lucy said, due to the availability of agency staff generally. Medical agencies on the increase, but not as much as last year. In terms of capital, I've still got a lot to do in the last quarter of the year. Well, in fact, in the next 6 weeks.
6 weeks.
Yeah. Of course, I'm referring to the paper which reports the position at the end of December. But you know, we have got a plan for £40 million, and at the end of December we'd actually spent 17. But we are monitoring this literally on a daily basis, and we are still confident that the majority of the schemes are going to come through by the end of the year. It's true, within the papers we are sat on an enormous cash balance at the moment of £54 million, but there are reasons for that which I've referred to in the report. And my final point is, colleagues may have noticed that we've introduced a new dashboard to try and explain the working capital and balance sheet, something I've been wanting to do for some time, and happy to take any comments outside of the meeting on that new approach, which hopefully injects a little bit more, I don't know, transparency and clarity into the working capital position. Thank you.
That's great, Howard. And can you ever remember in all your many years at Wye Valley sitting on such a cash balance?
Absolutely not. Absolutely
Happy
not.
days. Well done, Howard.
I've been looking at 1 or 2 million, not 50.
Any questions or perspectives to Howard? Andrew?
Yeah, just a comment really on related to that. It's good also to see that with that cash balance, we're making our payments to our creditors.
Absolutely.
Which has been a government initiative for through the COVID.
And certainly, you know, under Howard's leadership, Wye Valley has been at the leading edge of that within the foundation group in terms of fast payment of our suppliers. So well done, Howard. Any other comments? Okay, great. So the next item is an incredibly important item, given the horrific stories out of Morecambe Bay, out of Shrewsbury and Telford, and a series of really quite frightening reports into maternity services around the NHS. So the Ockenden report is an extremely important report. And just before we get into the detail, and it's great to have Joy, and I think Steph's now joined us, and Amber with us, is one of the things that pleases me is our transparency and openness in the report that's before us. So Lucy, are you going to do an introduction and then over to the team? How do you want to play it?
Very brief introduction really to welcome colleagues. Joy Payne, our interim head of midwifery, Amber Tahia, our clinical lead for maternity and obstetrics. And I think we've got Steph, but I can't see her, Steph Mansell, who's also here as associate head of midwifery. And just to say really that this report came through Quality Committee last week and is now coming to board for approval so that we can submit to NHS-I&E in line with their deadline of the 15th of February. But I think what Joy and Amber and Steph are going to do is just pop up a very brief PowerPoint presentation to summarise the detail that you find in front of you. So over to you, Joy and Amber. Thank you.
Thank you. Thank you. Good afternoon, everyone. Pleased to be here on such an important occasion in maternity services. As you're aware, this Ockenden report was published in December, and we've had national mandates and requirements to complete assessment tools, 2 assessment tools. It's been a very tight turnaround and it's been a very detailed piece of work. And I would say that we were already doing a detailed piece of work in the maternity services in Wye Valley, and this will just supplement what we're doing because we've made a lot of progress on issues in the last year. So if I can move on the slide. Thank you, Erica. So in the initial action plan, which you will see in the appendices of this report, we had to work on 7 immediate and essential actions, which we'll now call IEA, and they had 12 clinical priorities. As a trust, we were fully compliant with 3 of these IEAs. We were partially compliant with 8, and we were non-compliant with 1, which, as I reported last week, was out of our control because it was a nationally produced document, the clinical quality surveillance tool, and we've had to wait for the release of that before we can work on it. Then following this piece of work, we've undertaken the very detailed work, which you will see on the self-assessment tool, which was not exactly the easiest of tools to complete, but we have undertaken the work and we've identified 5 immediate clinical priorities. If we can move slide, please, Erica. So these clinical priorities, I've gone through the action plan again since last week, and actually these are all the priorities that we are either partially meeting. Well, I'd say we were partially meeting, and there's only about 2 that we're not meeting at this moment in time, which are both out of our control. So I'll just go through each point, and Amber and I will interact as whatever part of the report it is. So the implementation of the perinatal clinical quality surveillance tool, as I've said, that wasn't released. It is now released, and that will be part of our work going forward. We now know with this report that we're going to have increased external scrutiny by the LMNS on serious incidents and HIJ cases. So we're already, Lucy and I are already in conversations, and we've been to board meetings with the LMNS, and we're already in the process of establishing the mechanisms of how this will commence in April of this year. There also is a requirement, which is an absolutely appropriate requirement, that we have independent external investigation and scrutiny of non-HIJ incidents. I think we just have to be mindful in Wye Valley that we won't have the same number of incidents. If we align ourselves with Worcester, we would have increased workloads. We just need to be mindful of how we manage that going forward. And I expect one of the key things that we're doing on and working at this moment in time is restructuring and investing in the maternity governance team to improve on our governance, because we have had some issues there in the past couple of years, and we're making steady progress this year, but I'm in discussion with Lucy on how we take that forward. In IEA 2, the safety champion meetings didn't take place in the same way because of the COVID. Everything stopped in those critical months last year. These are recommencing in February of this year, and I know that dates have been put in place for that. The Oxytocin report requires, or the national team require, that we introduce a senior advocate role. So we're waiting on national guidance for that. There will be a national job description. I am unclear at what level that will be, but I have been mooted that there would be a senior advocate role for every 1,000 patients. So we'll have to take that into consideration going forward. Ensure evidence is available to provide assurance with the PMRT. We have really improved how we're undertaking that and completed it since we got the patient safety midwife in post. So we are compliant with that. Actually, it's just an improving picture all the time. And also ensuring increased engagement with women and their families. So last year in the COVID, we weren't in that greater communication through the MVP with women and their families, but this has been re-energized this year. And I attended a meeting myself, as I reported last week, and there was 33 people in that, and the women were very vocal and very happy to work with us. So now we're really establishing increased links. And Lucy and I are meeting with the Vice Chair next week to discuss the Oxytocin report with them. If I could move the slide, Erica, please, thank you.
So,
yes.
Yeah, I think I'll take over. Good afternoon, everyone, and thank you, Lucy, for your introduction. For immediate action, immediate and essential action number 3, we are already actually, the Oxytocin report wants the consultant-led multidisciplinary ward rounds twice daily, 7 days a week. In Hereford, we are doing a Monday to Friday consultant-led ward rounds twice daily. Saturday, Sunday, there are morning ward rounds which are consultant-led, and in the evening, either there is a telephone ward round, or if the consultant is in person present to deal with an emergency in the evening, they're doing consultant-led ward rounds at that time. But regularly, they're doing telephone ward rounds in the evening on Saturday and Sunday. We have already put it in our business planning, and it will be incorporated in the consultants' job plans very soon to do the in-person ward rounds on Saturday, Sunday evenings as well. So it will come very soon. With each contact with the ladies, we are doing a risk assessment, and there is a formal documentation. I'm just talking about now the action number 5. So there is formal documentation, but we are teaching and training our staff and making sure that there is formal documentation for every contact with the ladies when they come in, and we're putting in place certain fields on Badgernet which are mandatory to fill, so that we can't, documentation can't go up, you can't progress in to the next step unless you fill up those mandatory fields on Badgernet. Also, there's always a lead consultant, which is allocated at the booking visit of the lady, and that lead consultant will remain as a lead consultant throughout their antenatal care and intrapartum care, even if they have multiple admissions, and even if they have been reviewed by other consultant colleagues who are on call at that time. The lead consultant still remains the named consultant who the lady was booked in at their first booking visit. So that will remain the same in order to have the continuity of care. And we are working to ensure the development and implementation of personalized care of the ladies, and involve them in decision making, which I'm going to talk about later, because there's another immediate and essential action which covers that aspect. And Joy is going to talk about the Saving Babies Lives bundle. Joy,
so in relation to the Saving Babies Lives version 2, I've been told by the team that we are in compliance with it, but the team haven't been able to give me an action plan. So we've convened a group now that we have an action plan, and we're in the process of doing that, and that should be completed shortly. So if we're not totally compliant, we want to be far off it, but I need the assurance of seeing the completed work myself to be able to give you full assurance. Erica, could we move to the next slide? Thank you. Amber, did you want to talk to this one?
Yeah, so at the moment we have a labour ward lead consultant, and Ockenden wants a dedicated fetal well-being and fetal monitoring lead midwife and an obstetrician, consultant obstetrician. So we have a fetal well-being lead midwife, which Joy is going to talk about. And as regards to the lead obstetrician, that role is being covered currently by the labour ward lead consultant, but we have a business planning in place for this role, and it will be incorporated in consultants' job plans, which again, we're going to have it soon. And it will be a lead for fetal well-being and fetal monitoring lead consultant, which will work in close contact with the lead labor ward lead, so that that consultant will make sure that all the staff members, medical as well as midwifery, are up to date with their training, fetal monitoring training, in order to reduce any SIs or any incidences in the delivery suite relating to fetal monitoring and fetal well-being. I'll also discuss, before Joy takes over, I'll discuss point 7 as well. We are actually already on Badgernet. We have a field, which is again a mandatory field, where after making the management plan during their antenatal visit, we involve the ladies fully in decision making, which I said earlier. And once they are happy, there is a question whether the woman is happy with whether woman is involved in decision making, yes or no, and we have to click that. And if we click yes after discussing with the lady, then it asks us whether the woman is happy with the plan. And then you have to click yes or no. So ladies are fully involved in decision making for their mode of delivery, for their place of delivery, and once they are happy, only then those fields are clicked. And that's a good way of keeping in evidence and assurance that they are fully participating in decision making and informed choices. Joy?
Okay, and just related to the fetal wellbeing lead midwife, then, just to take us back one step. At the moment, we've got funding for 0.40 of a fetal wellbeing midwife from the LMNS, which will end on the 31st of March, but it'll roll over a little bit because we didn't appoint until a certain time. But when you read the Ockington report and the national requirements in a self-assessment tool, the remit on these people is going to be absolutely quite a large remit, I would say. And we know that there is a national and a worldwide issue in interpretation of the CTG. It's not just Y-value who might misinterpret the CTG. That is a common feature in all incidents. So I'm recommending to Lucy, and I'm going to discuss it with her, but I really think that we should make that a substantive whole-time equivalent post, because I think the scrutiny on this and the expected requirement is going to be quite substantive over the next few years. So that's just to make that point here. If I can just go on to the next slide. So the chairman has asked for assurance on these 5 questions, as you can see on the slide. So I can give you partial assurance, but I can give you assurance on what we're doing to tackle any issues going forward. So the first question is, do all staff provide compassion? Well, we have a very low incidence of complaints in Hereford. It's quite surprisingly low, actually. I have seen 2 complaints with slight staff attitude in it. One was an agency midwife and the other one was a midwife. And if we do see that, we do address those issues very quickly. And I really think that we have made immense progress in the past year. We're not through it, but we're really on steady trajectory to improving the culture within the organisation. So if we look at high-risk women giving birth in the wrong place, we don't have MLUs here in this area, but what I am seeing, which I think is worthy of mentioning, is that we are seeing an increased number of women wanting to have a baby at home who are high risk, and the most appropriate place for them would be to birth in the hospital. So we're trying to set up some sort of work streams between them, and we're needing to look at that as an organisation. In relation to number 3 and 5 and staff not being up to scratch, did you want to speak to this, Amber?
Yeah, I mean, we have a very organized training system where Teresa is doing trainings and consultants are involved in skills and drills. We are doing monthly skills and drills, and we have during COVID time done even fortnightly skills and drills where we make sure that the staff competence is up to date. And we have incorporated and introduced K2 now in mandatory training, which is a CTG training, because we had few incidences of where the CTG wasn't read appropriately. So if we pick up any point where we feel that the staff is not trained or it needs more updating of training, then we act on it. So at the new 2 introductions or K2 CTG package, and the other one is prompt training package from Royal College. So we have started those 2, and they are mandatory for all the staff to get trained into, and they get reminders. in order to address the issues with the reading of fetal heart rate monitoring and any mismanagement during intrapartum time of the ladies. So that's what where we are, and it is closely monitored, and the staff get reminders when they are due for their training.
And we're taking on K2 package, aren't we? We've invested in the K2 package and also in prompt to bring us in line with the LMNS and the foundation groups, that we've got the same training packages and that we're using nationally recognised training packages rather than in-house training packages. So all those are taking place in this quarter and the next quarter. So that's really good progress being made on that as well.
Yeah.
In relation to the inappropriate use of oxytocin, I haven't seen that, or Amber, we both haven't seen that in this unit. There's been nothing reported on it. And I think in Shrewsbury, they really were using oxytocin and things that they shouldn't have been, like breech deliveries, etc. So I have no evidence of that. So I feel quite confident that that's not happening at this point in time.
Yeah, it is not happening. I haven't seen a single case for so many years I'm here in this unit. So as regards to, if I go back to point 2, high-risk women giving birth in the wrong place, it's quite complex actually, that issue is, and it has been aggravated by COVID when they are worried coming to the hospital. But I mean, I have to say that even after COVID, once we'll successfully get out of this pandemic, there are certain ladies who, despite of all the counseling, they will still stick to their point and they want the delivery at home, understanding the risk factors. So, and again, it's informed choice, isn't it? And women involved in their choice. So it's a difficult situation. So as clinicians, our role is to give informed advice for the risks and then put in place all the safety measures for them. If they want to choose the route of having birth in the wrong place, for example, at home, then we can support. I mean, we want to make sure, then we must make sure that we are providing all the safety net system there for them.
Okay, thanks, Amber. Thank you. Just the last slide now. Thank you, Erica. So to give the assurance what we're doing, we've established a maternity safety working group to maintain the scrutiny and to make sure that we've got traction on all the actions that we've just discussed. The action plan will be monitored through that group and we will report it to the Quality Committee to give assurance going forward. I would just like to reiterate, we are really making steady progress in what we're doing in the services in Wye Valley. Thank you.
Thank you, Joy, and thank you, Amber. And I don't think Steph was able to join us on the line, so you know, can you pass on our thanks to all of the team, because like I said in my introduction, the thing that reassures me most is the openness and transparency of the description of the journey that we're on. But you've already had a phenomenal impact. Lucy, anything you wanted to say in conclusion? Oh, you're on mute, Lucy. Sorry,
can you hear me now?
Yes.
I think your summary is right, Russell, in that the assessment against the assurance tool has been undertaken openly, transparently by the multidisciplinary team. There's work in progress to address the matters where we're not quite there. And I think the convening of the group that Joy alluded to at the end is the right way to take this work forward.
Okay, great, thank you. Just really conscious of the time because we've had to spend an appropriate long amount of time on this because it is a very important issue. Glenn?
Yeah, we've looked at this in all 3 board meetings this week, haven't we, Russell? And I think it's been great to see that all of the teams have looked at the findings and the recommendations of the report and have taken an honest view about where we are as individual organisations. Actually, I think together the 3 trusts in the group can share that best practice and could work on the solutions. I've been a little bit worried about some trusts actually that have no sooner did the report landed on the desk and they were saying they're fully compliant, even though there's still some national guidance needed in some areas. So I think this will be a journey. It's important that we keep a focus on it, and we've obviously done a lot over the last year, 2 years to improve the safety of the department. And for what is a very straightforward and natural thing, it's a very complex, risky part of the NHS, and it's being given the right attention as part of this action plan.
No, great. Thank you, Glenn. And Richard?
Yeah, I just want to commend everybody for the huge amount of work that's gone in to get us to where we are. It's a reflection of how seriously we're taking this. But I also just wanted to reiterate a comment I made at the Policy Committee, which is about that we shouldn't be complacent about the importance of culture and behaviour and leadership. These are factors which have come out again and again and again in all sorts of inquiries into maternity services going back to Morecambe Bay. I was very reassured by what I heard at Quality Committee about what we're doing on that front, but we mustn't become complacent. Thank you.
No, absolutely, Richard. Some of you will know I used to be chairman up at Oswestry about 12 years ago in the early days, and I was horrified in my relationships with some of the people up at Shrewsbury and Telford that they weren't listening, and there was a blinkered attitude. So your point on culture, I think, is very important, Richard, and Joy and Amber and Steph and everyone. It's just about being open and honest. If you don't understand the challenges you're facing, you'll never come up with a proper route map to a better place. And I think that's what you've done phenomenally well as a team. And Joy, if I can just say, I adore your accent.
Oh, thank you.
I absolutely love it.
Well, I don't.
Well, I do. I'm an Essex boy, so we'll swap accents.
Oh, Gavin and Stacey.
We're going to Barry Island together.
Yeah.
But thank you very much for your hard work. And
thank you.
So just before we finish, team, we do need to approve this. If you're not happy to approve the work that we've seen, please raise your digital hand. Okay, super. Thank you very much again, Joy and Amber, and see you again soon. Thank you.
See you. Bye. Bye.
We do need to pick up the pace a bit, guys. Apologies, because I am conscious of the fact John's got a very important meeting coming up later. So the digital program update report, Howard and Dan, good to see you. Can't see you, but know you're there. Howard, are you going to introduce this or?
Yeah, absolutely. I'll be very brief, actually. I mean, I haven't done a digital update for 3 months now, but hopefully from the report, colleagues will see that we've continued to make progress, good progress, I think. And I was just going to provide 2 brief updates. One is that EPR, I referenced in there that we had to suspend nurse noting, but we have now agreed to begin again on the 1st of March in Lug and Arrow. So the next month preparing for that. So that kicks off again. And EPMA this week, we've gone live in ED and AMU. So so basically we continue to make good progress. Happy to take any questions.
Thank you very much, Howard. Dan, anything you want to add? Okay, can't see or hear you, Dan. So any questions or perspectives to Howard? Frank?
Yeah, just picking up on the one about the EPR team came up with a reporting system. I mean, that needs to be brought out and applauded, I think. But it raises something I was going to ask in the last session about BadgerNet. Where in the trust do we review things like the effectiveness of BadgerNet and how we might take information from it to help us drive decisions? Is there somebody that regularly does that?
To be totally honest, Frank, there isn't. But one of the things which we're looking at, which I'm really keen to try to introduce, is a clearer system of management of our clinical systems on an ongoing basis, which would include that very issue. We've got, as you know, we've got an increasing number of important clinical systems, and at the moment we don't have, from my perspective, a robust enough structure to manage them going forward. So it's a good point, noted, and certainly something we need to do in the future.
Just to endorse it, for example, if you're running out of stock in a business, you can get an email sent to somebody automatically. All of that sort of automation could be quite powerful. Thanks.
Yeah, Lucy, did you want to add something?
Yeah, it was just part of, we were one of the very early adopters of BadgerNet, and we have identified through the Ockenden review really a need to refresh our approach to its use, because we could exploit it more and then use it for audit purposes much more meaningfully than we currently do. And that's part of the discussions I'm having with Joy and the team on an ongoing basis about how we might do that within the governance team within maternity as well.
Okay, thanks Lucy, thanks Frank. Any other comments? Otherwise, duly note the report. Thank you, Howard, and continue to drive it forward, please. Then we're on to the quarterly mortality report. David?
Thanks, Russell. Yeah, it's another relatively good news story. So our overall mortality statistics are some of the lowest we've actually seen. Crude mortality remains low. I'm particularly pleased with the progress of some of the outlier groups. So these are the groups that we have the greatest concern about, specifically fractured neck of femur, which has reduced its mortality rate really significantly over the last 6 months since we started to sort of promote it to a outlier status. And the good news on that is we're about to appoint a full-time orthogeriatrician who ran a successful service in Milton Keynes, and obviously we've got the new wards being built, which will lead to a pathway change whereby the fractured neck of femur patients will be looked after approximately 48 hours by the orthogeriatric team rather than the orthopedic team. Heart failure remains is improving also, and there's some interesting work in terms of upstream intervention in both heart failure based on the respiratory experience we've had over the last 2 winters. I think that's probably all I need to say.
No, great. Thank you, David. And I think that moving upstream with this analysis to understand, for example, on heart failure, what we can do upstream to sort of improve the trends has to be the future of the way we think about integrated care and prevention. Questions or perspectives to David on mortality? Thank you, David. And so we'll move on then to the Freedom to Speak Up quarterly report. Jeff, great.
Oh, thanks, Russell. We've actually got the Freedom to Speak Up Guardian on the call as well. So maybe if I introduce the report, then she can give just a high-level summary, if that's okay.
That's fantastic. So, nice to see you then.
So following on from the board workshop we had, I think it was December, we had the workshop. So the report just presents information on the first 2 quarters of 2020-2021. And I think overall it's good to say that there's no significant concerns that we want to raise. So it's just about giving an update on where we are with Freedom to Speak Up events. So over to you, Dan.
Good afternoon, everyone. Yeah, thank you. I just give you, on top of the report, I'll just give you some quick assurances really that speaking up is alive and well in WVT, moving forward, albeit at a different pace because of COVID. As the executive summary says, we know it provides assurance that activities are going on. This is limited and challenging in these times, but I just want to say that I'm frequently in contact with my champions to make sure that it's still, as they're clinical, it's still in the forefront of their minds to keep it alive and well in their scope of practice as well. I try and jump in on as much training as I can, virtual training. So I think last year I spoke to going on for 100 preceptorship nurses. So I have to use other ways of getting myself out and about and getting the message out there. I think the policy was updated at the end in December. And I think we're meeting a lot of the national objectives that we should be. We did, as Jeffrey said, we did our workshop in December, and there'll be an action plan that will come out of that, including a strategy, which we will be working with Swift and George Eliot to do something in combination with us all. And I'm starting meetings with that actually on Monday. So that will be starting. And actually in January, the National Guardian, Henriette Hughes, came into our regional meeting and presented the 5-year strategy for the national Freedom to Speak Up movement. So we'll have to align with that. And I think today was final comments on that before it goes live. And I have made comments through our regional team on that. So we will align ours with those new strategies that are coming in nationally as well. And I think anything else really where there was a few, I think nursing reporting went down in Q2, but I can say that's coming back up again now in Q3. Seems to have been levelling out. A few highlights there. Medical staff starting to come on board, and with speaking up, but they're still in a minority, along with our BAME group of staff and generally males. It's generally females that are doing the majority of the speaking up. Now there's a surprise. And I think the other big thing that's come out, and it was agreed with the board at the last meeting, was not this meeting, in the Monday meeting, is that training has been released nationally. So for all workers was released last year. For managers was released that last month. I can't believe we're in February already. So it was released in January. And for senior members will be released later on in the year. So we've agreed that that will get embedded into our training package. Probably not till the end of the year, because it's not right. It's not the right time to be releasing new training while we're struggling to get everything else done. And I'm starting talks with that with our EDC department in the next couple of weeks on how we're going to manage that. I think the model hospital as well, we're in the culture and engagement session. So there's some, I've just pulled off a couple of examples there with regard to patient safety and detriment. And just for people who might not be aware, everything is recorded on my database and in my national reporting as the perception of the person who comes forward. So that's that. I don't make that judgment. It's what they feel they're speaking up about that gets reported. I think if anybody's, I think that's, I think we're online to be about the same as last year for numbers. It's been a bit of a strange year in that we've been up and we've been down on certain things, but I think that's the nature of where we are at the moment.
Thank you, Dan. Thank you, Jeffrey. Any questions or perspectives to Jeffrey or Dan on the Freedom to Speak update report? Frank?
Yeah, on the rumour mill, we sometimes see some emotive comments. And the disappointment I feel is I wish they'd have gone to Freedom to Speak Up with that and been more open. It help with the analysis. The response on rumour mill never says, please go and speak to Freedom to Speak Up. And I just wonder if we should try and triangulate the two.
Jane?
I mean, generally our advice would be to go and speak to the line manager and really, if their line manager is the problem, or go to Freedom to Speak Up, or if they feel like they're not getting a hearing, the line manager. But we'd certainly say Freedom to Speak Up is the safety net and not where we'd advise people to go first of all, certainly straight to their line manager. And
Glenn?
Yeah, before we next meet as a board, the National Staff Survey will have been published. I'm not allowed to talk about it until it's been published, but I look at about 10 key indicators on that, and actually compared to last year we're up in 7 of those, and significantly up in 3. And one of the ones that we always stand out very well on, in fact best in the group, is on reporting of incidents. So there's a really good safety culture in the organisation, and that will come out very strongly in this latest annual staff survey, which we'll obviously make a bit of noise about.
But we're not talking about at the moment.
Not allowed to.
Okay, Dan?
Just that once that staff survey comes out, then the 4 questions that feed into the Freedom to Speak index will then release. We'll be able to, even if it's not released, I'll be able to work out whether we've gone up, down, stayed the same. So that'll be good as well. That'll give us a good indication of where we are.
That's great, Dan. Thank you. And thank you for all your hard work, because it can be a bit lonely sometimes being the Freedom to Speak Up Guardian. And Jeff, thanks for your leadership as well. Okay, we'll move on then, team, to the Emergency Department. No, we won't. We'll move to the Board Assurance Framework and Risks. Erica.
It's just to say, Chair, it follows the normal format. It's the risks that the Trust has against us achieving our strategic objectives. I think the final column is key, with the actions that we're taking to drop those current risk scores further. But the trend is that the risks are in the main reducing.
Thank you, Erica. Any questions or perspectives on the update? Okay, team, everyone happy to move on? So we will come to the Emergency Department Transformation Business Case, which is an important one. Obviously, Alan, we've been able to review it and it's been talked about before, but what would you like to pull out?
Yeah, I'll take the report as read, Chair. Thank you. It really is here for information, as it's already been approved offline. But we're sort of completing the process by bringing it to board here today. Just to summarise very briefly, three main elements that this £2.5 million scheme delivers, all within our ED department. It gives us access to same-day emergency care facility. It deals with a number of issues to improve flow at front of house, and thirdly, the other main area is around our clinical assessment unit and improving the facility there. Make some significant improvements for patients there. As this has already been approved, the work has already begun, and I'm pleased to say it's all on programme. Expected to complete by the end of March, with the SDEC element of the scheme, sort of brand new facility there, opening at the end of February. So that's just the update on this paper.
Super, thank you very much, Alan. Any questions or perspectives on this? Nicola?
Hi, yeah, Alan, when we were building the new wards and right at the beginning, there were some really good videos showing progress. I'm just really conscious now, we never get in to see anything, see what's happening. And I just wondered if there's something that can be done the same to really give 3 dimensions to what you're doing there. Because I think this is a really exciting project. For most people, emergencies where the place where you don't want to go, but when you get there, you want to know it's the best when you're in. So that would just be really good if we could have something.
Okay, thank you. I'll ask the contractors to do that.
Okay, thank you. And Andrew?
Yeah, when we agreed it offline, there was some discussion about post-benefits appraisals and quantifying them, which you mentioned. I think my point would be, can we have, or would it be appropriate for the board to have some timescales as to when those quantified benefits would come back to the board?
Yeah, it's something that we were going to pick up through our operational planning approach, because we're going to take a wider look at ED within operational planning. So I would expect that around April time.
And any other questions or perspectives? I do think, just building on what Andrew said there, having a regular timeframe for post-investment reviews is just good practice. And to separate out operational post-investment and financial post-investment review, I think would be wise. Okay, so we've already signed this off, guys. So everyone happy to note? Thank you. So we'll move on then to the committee reports. The first is the Audit Committee of the 10th of December. Andrew, anything you want to add to this?
Not really, other than the main item I was bringing to the board's attention is a very positive one. We had a really good presentation from Hannah Martin on the reporting of the financial position and how it is built from baseline, right from the bottom of the organisation through to the board, and gives the board a fair degree of assurance, I think. But it was an excellent presentation to the Audit Committee. Otherwise, take it as read.
Thank you, Andrew. Any questions to Andrew? Thank you, Andrew, for your leadership of that and your involvement in the ICS's Finance Subcommittee. The charity trustee meeting of the 10th of December. Frank?
Nothing to add. Take the report as read, please.
Any questions to Frank? Okie dokie. And then the quality committee of the 26th of November and the 17th of December. Chris.
Thank you, Chair. No, nothing additional to say, except, as you might imagine, we are operating a very streamlined approach, but ensuring that we discuss the most important things that we need to. So be assured on that.
Okay, and thank you for your empathy towards the executives during these challenging times. Any questions to Chris on those reports? Okie dokie. And then we've got the Foundation Group Strategy Subcommittee at the 26th of January. Richard, anything you want to add?
Not really, Chair. This is just a briefing note to set out what we discussed, and the formal minutes will follow in due course.
Okay, super. I think it was a fruitful meeting though, Richard, and kicked off the calendar year with a full sense of drive and purpose. Any questions to Richard? Okay, and then we've got some old committee minutes from the Audit Committee of the 17th of September. Andrew, anything you want to add?
No, they're fine.
Thank you. The Charity Trustee meeting of the 17th of September, anything you want to add, Frank?
No, thank you.
The Quality Committee of the 29th of October, anything you'd like to add, Chris?
No, Chair, nor for the November one either. Thank you.
Thank you. Any questions on any of those? Bless you, Jane. And therefore, I think we're on to any other business. Any other business? Please raise your hand if we have any other business. And I don't think we've had any questions from members of the public, Erica. So any members of the public who are watching this YouTube later, we would really welcome and encourage you to ask any question you'd like of the board. In the meantime, we look forward to seeing you at our next board meeting on the 4th of March. Please take care. Please remember to continue to socially distance, wear a face mask, wash your hands, and as soon as you're called to have a vaccination, please go along and support your loved ones by having the vaccination done. Thank you.